This is the full dose of rheumatoid arthritis from Therapeutics Drive clinical learning for pharmacists on the go.
It's great to be here.
So if you work in a pharmacy, whether you're, managing a really busy community dispensary or you're reviewing charts on a clinical ward, there's this one specific scenario you just encounter
Oh,
constantly.
absolutely.
Right. So a patient walks up to the counter. Let's call her Sarah. She's maybe in her late 30s. She's picking up her fourth consecutive prescription for prednisolone, a box of ibuprofen, and she just looks completely exhausted.
Yeah, you see that exact picture all the time.
And if you look closely at her hands, you might notice this slight swelling around the knuckles. And for months, she's been told she has, I don't know, a bad virus, or maybe early onset osteoarthritis, or that she's just stressed out.
Which is incredibly frustrating for the patient.
Exactly. But when that definitive diagnosis finally lands, her entire medication profile is going to transform literally overnight. I mean, we're talking about multiple heavy-hitting immunosuppressants, really meticulous dosing schedules, and massive safety considerations.
It really is a profound shift in therapy.
Mm-hmm.
And it places the pharmacist squarely on the front lines of patient safety. I mean, rheumatoid arthritis, or RA, it has a global prevalence of roughly 1%. So we see it constantly in the Australian healthcare system.
Right. It's very common.
But the clinical challenge actually begins long before that prescription ever reaches your pharmacy. Because RA is notoriously delayed in diagnosis. The early symptoms are they're incredibly insidious and nonspecific.
Like, what kind of symptoms are we talking about initially?
Well, patients present with profound fatigue, generalized weakness, maybe a vague loss of appetite, and just diffuse musculoskeletal pain. So they spend weeks, sometimes months, thinking they just have lingering post-viral fatigue, or they're just dealing with normal aches and pains.
And that delay is a massive problem, right? Because of the underlying pathology. I think there's this pervasive misconception, even sometimes bleeding into primary care, that RA is essentially just bad joints.
Yeah, people conflate it with osteoarthritis all the time.
Right, but if we break this down, osteoarthritis is really a mechanical issue. It's like the slow, progressive wearing down of a car's brake pads over, 100,000 kilometers.
That's a great way to put it.
But rheumatoid arthritis is a completely different beast. RA is like the car's internal alarm system short-circuiting, locking all the doors, and actively reprogramming the navigation to just intentionally crash the car. It's a systemic fire.
I'd actually take that analogy a step further. It's not just crashing the car, it's setting up a localized factory inside the joint to manufacture corrosive acid.
Wow. Okay.
Because RA is a systemic inflammatory autoimmune condition. And the real-world impact for the pharmacist managing this condition is immense.
Because of the medications we have to use to treat it.
Exactly. We're using medications designed to suppress the body's entire immune system to put out that fire. So the pharmacist really acts as the ultimate safety net. We're dispensing conventional synthetic drugs, large molecule biologics, targeted synthetic small molecules.
And these aren't just your standard daily meds.
No, not at all. These agents are teratogens, they're profoundly immunosuppressive, and they carry severe boxed warnings. I mean, a single prescribing error, like dispensing a specific drug for daily use instead of once weekly use, that can lead to irreversible bone marrow suppression and quite literally death.
Which is terrifying, but it's why we're here. Our goal with this deep dive is to master the therapeutics of RA based on the Australian Therapeutic Guidelines, the ETG, so you know the exact clinical nuances to look for when those authority scripts cross your bench.
Absolutely.
So let's start by unpacking that systemic fire. We know it's an autoimmune reaction, but how does the body actually turn against itself? Like, what pulls the trigger at the cellular level?
Well, the underlying pathogenesis actually begins years before Sarah ever feels a swollen joint. It requires this perfect storm of genetic susceptibility and environmental triggers.
So it's not just one or the other.
Right. Genetically, there's a very strong correlation with the major histocompatibility complex class 2, specifically the HLA-DRB1 alleles.
Okay, the HLA genes.
Yeah, and these genes basically code for the receptors on antigen-presenting cells that display proteins to the immune system. In RA patients, these receptors have a specific sequence called the shared epitope, which seems really prone to binding certain autoantigens and presenting them to T cells as if they were dangerous foreign invaders.
But just having the gene doesn't guarantee the disease, right? You need that environmental trigger to actually set the whole cascade in motion.
Precisely.
And looking at the research, the triggers are fascinating. Like, we know biological sex plays a role. Women are affected at a 3-to-1 ratio compared to men, which heavily points toward hormonal influences on the immune system.
Yes, hormones are definitely a factor.
But the modifiable environmental triggers are what really stand out in a clinical consultation. Like, tobacco smoking is a massive catalyst, right?
Well, smoking is arguably the most critical modifiable risk factor. And the mechanism is just brilliant, clinically speaking.
How so?
Well, smoking causes severe oxidative stress in the lungs, right? And this stress activates an enzyme called peptidylarginine deaminase, or PAD.
PAD, okay.
And this enzyme performs a process called citrullination. It actually converts the amino acid arginine, which is normally present in lung proteins, into an atypical amino acid called citrulline.
Oh, and because citrulline isn't normally recognized in that configuration by the body, the immune system looks at these newly citrullinated lung proteins and just flags them as foreign.
Exactly. The immune system mounts an attack. It starts producing anti-citrullinated protein antibodies, or ACPA.
Which is a marker we test for.
Yes, exactly. This immune reaction starts in the mucosal surfaces of the lungs, but eventually those antibodies circulate systemically and find their way to the joints, where similar citrullinated proteins naturally exist.
Wow. So the lungs essentially prime the immune system to attack the joints.
That's it. And what's crucial for pharmacists to counsel on is that smoking fundamentally alters the immune response. Current smokers have significantly higher disease activity and a much lower chance of achieving remission on medications.
So quitting is essential.
It is, but the risk of developing RA or experiencing severe disease actually remains elevated for years after cessation compared to someone who has never smoked. The immunological memory has already been written, unfortunately.
That's wild. And beyond smoking, the sources point to other mucosal surfaces too, right? Like occupational inhalation of silica dust, heavy air pollution, and even the gut microbiome.
Yeah, the microbiome research is fascinating.
Like an altered composition of bacterial species in the gut, dysbiosis, that can shift the balance of mucosal immunity too, basically priming those T cells for an autoimmune attack.
It really perfectly illustrates why RA is a systemic disease right from day one. But let's zoom in on the exact mechanics of the joint destruction.
Yeah, let's get into the joint itself.
Once the systemic immune response homes on the synovial fluid of a joint, the main driver of the pathogenesis is the T lymphocyte. And for a T cell to become fully activated and, unleash destruction, it requires a very specific double authentication process.
A double authentication process, like turning two separate keys to launch a nuclear missile.
Exactly like that.
I want to break down those two keys because this directly translates to how our biologic drugs work later on.
It absolutely does. So the first key is antigen presentation. An antigen-presenting cell, like a macrophage or a dendritic cell, engulfs an autoantigen, breaks it down, and displays it on its surface using that HLA-DR receptor we mentioned.
Okay, so showing the antigen to the immune system.
Right, and the T-cell receptor binds to it. That's signal 1. But signal 1 alone actually does nothing. In fact, without signal 2, the T-cell becomes anergic. It just shuts down entirely to prevent autoimmunity.
Oh, so what provides the critical second key then?
The second key is a co-stimulatory handshake. The antigen-presenting cell expresses these surface molecules called CD80 and CD86, and the T cell has a receptor called CD28.
Okay, I'm following.
When CD80 or 86 physically binds to CD28, the circuit is completed. The T cell activates, and once it activates, the inflammatory cascade just absolutely explodes.
This is the cytokine storm we hear about. The activated T cells start dumping massive amounts of chemical messengers. They stimulate local macrophages, which then release the big players we really need to remember, right? Tumor necrosis factor alpha, interleukin-1 and interleukin-6.
Yeah, TNF-alpha, IL-1, and IL-6.
Yeah.
They're the architects of the joint's destruction. They flood the synovial tissue, and they basically do 3 terrible things.
Okay, what's the first one?
First, they stimulate fibroblasts like synoviocytes and chondrocytes to release matrix metalloproteinases.
That's a mouthful.
It is, but basically they're digestive enzymes that literally chew up the collagen and degrade the connective tissue and the cartilage.
Yeah.
Second, they stimulate B lymphocytes to differentiate into plasma cells, churning out massive quantities of rheumatoid factor and those ACPA antibodies, which just feeds the whole cycle.
And the third thing is what causes the irreversible bone damage, isn't it? They upregulate a protein called RANKL, which binds to receptors on osteoclasts.
Precisely. Osteoclasts are the cells responsible for bone resorption. Now, in a healthy body, they remodel bone safely. But in an RA joint bathed in TNF-alpha and IL-6, osteoclasts go into overdrive, just aggressively destroying the bone beneath the cartilage.
So when a pharmacist looks at an X-ray report for an RA patient, they might see the word penis. What is physically happening in that joint space to create that?
Well, the normal synovium is this very delicate membrane, maybe 1 or 2 cell layers thick, that produces the lubricating synovial fluid. But under the influence of this cytokine storm, that membrane undergoes severe hyperplasia.
It thickens up.
Massively. It thickens into a dense cellular inflammatory tissue known as the pannus. This pannus behaves almost like a localized benign tumor. It undergoes angiogenesis, meaning it sprouts new blood vessels to feed its own growth.
Wow, it builds its own blood supply.
Yeah, and it invades the joint space, physically covering the cartilage, depriving it of nutrients from the synovial fluid, while those enzymes and osteoclasts just degrade the structures from the inside out.
See, here's where the clinical consultation gets really challenging. Like, if I'm counseling Sarah at the pharmacy, we talk a lot about protecting her joints, right? The pannus, the cartilage, the bone. But then she mentions her rheumatologist told her she's at a high risk for a heart attack.
Ah, yes, the cardiovascular link.
And a lot of patients assume this is just a lifestyle consequence. They think, my joints hurt, so I can't exercise, so I gain weight, and that hurts my heart. Is it just a secondary lifestyle effect?
That is a brilliant point to raise, and the answer is a definitive, emphatic no. It is not just about a sedentary lifestyle. Cardiovascular disease is actually the leading cause of mortality in rheumatoid arthritis.
A leading cause, really?
Yes. More than half of all deaths in RA patients are cardiovascular related. RA is an independent cardiovascular risk factor. It carries a weight similar to having type 2 diabetes.
Independent, meaning the pathophysiology of RA itself directly damages the cardiovascular system.
Exactly. We have to return to that systemic fire concept, that massive overproduction of TNF-alpha and IL-6. It doesn't just stay neatly confined to the knee or the wrist. It spills over into the systemic circulation.
Okay, so it goes everywhere.
Right, and this drives the liver to produce acute phase reactants like C-reactive protein or CRP. The systemic cytokines attack the endothelial lining of the blood vessels, causing severe endothelial dysfunction and accelerating atherosclerosis.
It's actively building plaque.
Worse than that, the plaque buildup inside the arteries of an RA patient is highly unstable and very prone to rupture because it's actively infiltrated by inflammatory macrophages.
Wow. And there's a fascinating lipid paradox here too, isn't there? Because we're taught that high cholesterol is bad. But in active, untreated RA, their lipid levels might actually look artificially low.
Yes, the lipid paradox is a crucial piece of clinical pharmacology. Severe systemic inflammation actually decreases total cholesterol and LDL levels.
Which sounds good on paper.
But it's not, because those lipid particles undergo oxidative modification. They become highly atherogenic. So despite a seemingly normal or low LDL on a blood test, the patient's cardiovascular risk is actually skyrocketing.
So what happens when we treat them?
When we initiate an effective DRA and put out that inflammatory fire, their LDL levels might actually rise back to their natural baseline. A pharmacist might see that lab result and worry the drug is causing hyperlipidemia, but often it's just a sign that the systemic inflammation is resolving.
That's so counterintuitive, but so important to know.
Ultimately, aggressively suppressing the RA is the absolute most effective way to reduce their cardiovascular mortality.
That really reframes the entire goal of our therapies. When you dispense an immunosuppressant, you aren't just saving their hands, you're actively protecting their heart.
Exactly.
And because we're dealing with a dysregulated immune system, there are other hidden dangers too, right? Like comorbidities and increased risk of specific malignancies.
Yeah, because the immune system is in chronic overdrive, there's a significantly increased risk of lymphoproliferative malignancies. Lymphomas are particularly common, as the B cells are constantly being stimulated to proliferate, which increases the chance of a malignant mutation.
Are there any other cancers we worry about?
There's also an increased risk of melanoma and lung cancer, and that's independent of their smoking status.
Okay, let's bring this to the diagnostic phase, because a huge part of community pharmacy is triage. A patient asks for advice on joint pain, and you're trying to decide if they just need some paracetamol or if they need an urgent referral to a GP or a rheumatologist. How do we differentiate the clinical presentation of early RA from regular osteoarthritis?
The clinical history gives you very distinct clues. Osteoarthritis has a very slow, insidious onset over years. It primarily affects weight-bearing joints, like the hips and knees, or the distal interphalangeal joints of the fingers.
Right, the ones closest to the fingernail.
Exactly. And the stiffness in OA is usually worse after activity and gets better with rest. Morning stiffness in OA is brief, almost always resolving in under 30 minutes.
But RA behaves entirely differently.
RA has a rapid onset, typically developing over just a few weeks to a few months. It targets the small joints, specifically the metacarpophalangeal joints, the main knuckles, and the proximal interphalangeal joints in the middle of the fingers.
So different joints entirely.
Yes. The wrists and the small joints of the feet are also classic targets. The pain is accompanied by visible swelling, warmth, and just an almost paralyzing stiffness.
And the hallmark metric we ask about is the duration of morning stiffness, right?
Yes, the classic red flag is profound morning stiffness lasting more than 60 minutes. During sleep, the lack of movement allows the inflammatory cytokines and edema to just pool heavily in the synovial tissue.
So they wake up completely locked up.
Literally. It takes the patient an hour or more of movement to manually pump that inflammatory fluid out of the joint via the lymphatic system so they can even just make a fist or hold a toothbrush. Furthermore, the joint involvement is characteristically symmetric. If the left wrist is inflamed, the right wrist is likely inflamed as well.
And if the disease is left unchecked, we start seeing those classic deformities, right? Like the swan neck deformities where the middle joint bends back and the top joint bends forward, or the boutonniere deformities.
Yes, irreversible structural changes.
Plus, because it's systemic, you look for extra-articular manifestations. Rheumatoid nodules, which are those firm subcutaneous lumps that usually form on pressure points like the elbows. They can also experience severe ocular inflammation like scleritis or even interstitial lung disease.
To confirm the diagnosis, the rheumatologist relies heavily on lab markers. The presence of rheumatoid factor, or RF, is common, but it's really important to remember that up to 30% of RA patients are seronegative for RF.
So a negative RF doesn't mean they don't have RA.
Exactly. The more specific marker is the anti-citrullonated protein antibody, the ACPA we talked about earlier. If a patient is ACPA positive, it is highly specific for RA, and it usually predicts a much more aggressive, destructive disease course.
So Sarah gets her diagnosis. She's ACPA positive. What is the clinical philosophy for her treatment? Because the Australian Therapeutic Guidelines dictate a treat-to-target approach. How does that translate to the prescriptions we actually see?
Treat-to-target is a strict algorithmic approach. We don't just give the patient NSAIDs, ask if they feel a bit better, and leave it at that. We define a specific clinical target.
Like total remission.
Ideally complete clinical remission, or at least very low disease activity, measured by standardized scoring systems like the DAS-28. We initiate early, aggressive treatment with disease-modifying antirheumatic drugs, or DMARDs. We measure their disease activity every 1 to 3 months.
And if they aren't hitting the target?
If they haven't hit the target, we escalate therapy. We do not wait. The absolute rule is that joint damage is irreversible. We have a very narrow window of opportunity to halt the osteoclasts before the bone is permanently degraded.
The urgency makes total sense, but there's a pharmacological delay we have to manage, isn't there? I like to explain this to patients using a construction analogy.
Oh, I like analogies. How does that one go?
Well, if the DMARDs are the heavy construction crew coming in to completely rebuild the neighborhood and permanently put out the deep-seated fires, they are incredibly slow to mobilize. They take weeks, sometimes up to 3 to 6 months, to reach their full therapeutic efficacy. But the patient is sitting in front of you today and their joints are actively on fire. We need emergency responders immediately.
And those emergency responders are the corticosteroids. This is what we refer to in the ETG as bridge therapy.
Bridge therapy, right.
Because the conventional DMARDs take months to work, we bridge that gap by prescribing low-dose oral glucocorticoids, typically prednisolone at a dose of 10 milligrams a day or less.
And steroids are just magic for inflammation.
They are incredibly potent. They cross the cell membrane, bind to glucocorticoid receptors in the cytoplasm, translocate to the nucleus, and directly switch off the genes responsible for producing those inflammatory cytokines. They provide rapid, profound symptomatic relief, and they actually slow radiographic joint damage while we wait for the DMARD to reach steady state.
But this is where the pharmacist's intervention is critical. Those emergency responders are not meant to stay on site permanently.
Absolutely not. The recommended duration for bridge therapy is generally 3 months or less, aiming to taper off completely as the DMARD kicks in.
So if a patient is regularly dispensing their daily prednisolone 6, 9, or 12 months down the line?
Alarm bells should be ringing. The adverse effect profile of chronic systemic corticosteroids is devastating. It actively induces osteoporosis by inhibiting osteoblasts and stimulating osteoclasts. It causes Cushing's syndrome, severe hyperglycemia, peptic ulceration, cataracts, and a massive increase in opportunistic infections.
So if they can't get off the steroid, what does that mean?
If a patient cannot taper off their prednisolone without flaring, it indicates their primary DMARD therapy has failed. The pharmacist must intervene, contact the prescriber, and advocate for escalating the DMARD regimen rather than just accepting chronic steroid use.
Okay, let's walk through that exact escalation pathway. We have a newly diagnosed patient, DMARD naive. What is the cornerstone of therapy according to the ETG?
Regardless of whether the patient has low, moderate, or high disease activity at presentation, the undisputed first-line therapy is methotrexate.
Methotrexate.
Yes. It's the preferred conventional synthetic DMARD, or CS-DMARD. Its efficacy is just unmatched in this class. Its long-term safety profile is well understood when monitored correctly, and it provides the baseline upon which almost all subsequent therapies are built.
Let's do a really deep dive into methotrexate, because in Australia, we frequently see it prescribed under the brand name methoblastin, though generic brands are super common too. Most pharmacists know it inhibits folate, but let's explain the exact mechanism and why the dosing schedule is so incredibly unique.
Okay, so methotrexate is a structural analog of folic acid. Its primary mechanism of action is competitively binding to and inhibiting an enzyme called dihydrofolate reductase.
Dihydrofolate reductase.
Right. This enzyme is crucial for converting dietary folate into its active form, tetrahydrofolate. Tetrahydrofolate is an essential carbon donor required for the synthesis of purines and pyrimidines, the building blocks of DNA.
So without it, cells can't divide.
Exactly. By starving the rapidly dividing immune cells of these building blocks, it halts the proliferation of the T cells and B cells that are driving the systemic fire.
But the critical pharmacological quirk is what happens after it enters the cell.
Yes, this is fascinating. Once methotrexate gets inside a cell, an enzyme adds multiple glutamate residues to the molecule. This process, polyglutamation, dramatically increases the size and polarity of the methotrexate molecule.
So it gets too big to leave.
Precisely. It traps it inside the cell. It cannot easily cross the cell membrane to exit. Therefore, even though the drug is rapidly cleared from the blood, the polyglutamated methotrexate accumulates inside the immune cells, exerting a sustained, prolonged immunosuppressive effect.
And that intracellular trapping is precisely why the dosing schedule is what it is. And I cannot stress this enough. This is the single most important safety check for a pharmacist dispensing methoblastin.
Without a doubt, methotrexate for rheumatoid arthritis is dosed strictly once weekly, never once daily. The typical starting dose in Australia is between 10 to 15 milligrams orally, once a week, often titrated up to 20 or 25 milligrams weekly. Because of that intracellular accumulation, a single weekly dose maintains efficacy for the whole week.
If a prescribing error occurs, or, a patient misunderstands the label and takes 15 milligrams daily, the results are catastrophic.
It is a medical emergency. Daily dosing rapidly leads to profound, life-threatening bone marrow suppression, severe mucosal ulceration throughout the entire gastrointestinal tract, hepatotoxicity, and often death.
Wow. So we have to be so careful.
You do. The pharmacist must explicitly write once weekly on the dispensing label. You must look the patient in the eye, verbally confirm they understand it's only taken on one specific day of the week, and ask them which day they intend to take it, just to ensure complete comprehension.
And to mitigate the toxicities of folate depletion, we always see folic acid co-prescribed.
Concomitant folic acid supplementation is mandatory. Typically, it's dosed at 5 milligrams once a week, usually taken 24 to 48 hours after the methotrexate dose, or sometimes 1 milligram daily.
I've had patients worry that taking the folate will just cancel out the drug.
Yeah, that's a common fear. But the clinical reality is that the folic acid rescues the healthy, rapidly dividing cells, like the mucosal lining of the mouth and the gut. It prevents severe stomatitis, nausea, and alopecia without significantly compromising the immunosuppressive efficacy of the methotrexate within the inflammatory cells.
Okay, now what happens if Sarah comes back in 3 months? She's taking her methoblastin weekly, she tapered off the prednisolone, but her DAS-28 score is still really high. She has not reached remission. The ETG tells us to escalate. What's the next step?
If monotherapy is insufficient, the ETG recommends escalating to combination conventional synthetic DMARD therapy. A classic approach is adding sulfasalazine and hydroxychloroquine to the methotrexate, creating a triple therapy regimen.
Let's break those two agents down. Sulfasalazine, commonly prescribed as salazalpine. How does that fit in?
Sulfasalazine is actually a prodrug. It consists of a sulfapyridine molecule linked to a 5-aminosalicylic acid, or 5-ASA, molecule by an azo bond.
Okay, so it has to be broken down in the body.
Right. When it's taken orally, only a small amount is absorbed in the upper GI tract. Most of it travels to the colon, where specific bacterial enzymes, azoreductases, cleave the bond. The 5-ASA provides localized anti-inflammatory effects in the gut, but the sulfapyridine is absorbed systemically and exerts the DMARD effect for the joints.
The counseling points for salazalpine are pretty crucial, though, right?
Very. First, you must assess for a sulfur allergy. If they're allergic to sulfonamide antibiotics, they must avoid this. Second, the dose needs to be titrated slowly. We often start at 500 milligrams daily and titrate up to 2 grams daily in divided doses, just to minimize severe gastrointestinal intolerance.
And the color change. We have to mention the color change.
Oh, absolutely. You must warn the patient that sulfasalazine can cause a harmless but visually alarming yellow-orange discoloration of their urine, sweat, and even tears. If you don't warn them, they'll end up in the emergency department convinced they're experiencing severe liver failure. It also causes photosensitivity, so aggressive sun protection is essential.
Right. And the other common add-on is hydroxychloroquine, known widely as Plecanil. Originally an anti-malarial, but highly effective in rheumatology.
Hydroxychloroquine operates differently. It's a weak base that accumulates massively inside the acidic lysosomes of antigen-presenting cells. By increasing the pH inside these lysosomes, it disrupts their ability to process and present autoantigens to the T cells, effectively muting signal 1.
And it's usually pretty well tolerated compared to the others.
It is, and it lacks the severe myelosuppression and hepatotoxicity of methotrexate.
But it has a very specific silent toxicity that requires vigilant screening.
Yes, retinal toxicity. Hydroxychloroquine binds strongly to melanin, meaning it concentrates in the retinal pigment epithelium of the eye. Over years of accumulation, it can cause irreversible maculopathy, leading to permanent vision loss.
And the patient won't feel it happening.
Exactly. The toxicity is completely silent until the damage is done. Therefore, every patient requires specialized ophthalmologic examinations at baseline, and then annual screening typically starting after 5 years of continuous therapy, or sooner if they have risk factors like renal impairment.
There is one more major conventional synthetic DMARD we need to cover before moving to the advanced therapies, and that's leflunomide, frequently seen as Arava. Its efficacy is comparable to methotrexate, but its pharmacokinetics are just fascinating.
Leflunomide inhibits a completely different enzyme, dihydrorotate dehydrogenase, which is essential for the synthesis of pyrimidines. Without pyrimidines, the massive clonal expansion of activated T cells is halted. But as you mentioned, its pharmacokinetics require intense pharmacist oversight.
The issue is its exceptionally long half-life. Why does it linger in the body for so long?
Leflunomide undergoes extensive enterohepatic recirculation. After it's metabolized in the liver to its active form, it's excreted via the bile into the intestines.
So it's about to leave the body.
Right, but instead of being fully eliminated in the feces, it's reabsorbed back into the portal blood circulation, returning to the liver. This creates a continuous loop, a massive reservoir in the body. The half-life is roughly 2 weeks, meaning it can take up to 2 years for the drug to be fully eliminated from the body after the patient stops taking it.
2 years. That poses a massive clinical problem if the patient develops severe hepatotoxicity, which is a known risk with Arava, or if a female patient decides she wants to conceive, as the drug is highly teratogenic. You can't just tell them to stop taking it and wait 2 years.
Exactly. If rapid clearance is required, we must execute a mandatory washout procedure using cholestyramine. Cholestyramine is a bile acid sequestrant, an ion exchange resin.
So it basically traps it.
Yes. When taken orally, it binds to the leflunomide in the gut, interrupting that enterohepatic loop. It traps the drug in the intestines and forces its excretion in the feces, reducing the clearance time from years down to about 11 days.
Okay, let's step up the ladder. Sarah has tried methoblastin. We added salazoprin and Plecanil. She's compliant, but the x-rays show early bone erosions, and her systemic fire is still raging. According to the ETG, it's time to escalate to the biological disease-modifying anti-rheumatic drugs, the DMARDs. These are the modern miracles of rheumatology. Let's start with the largest and most common class, the tumor necrosis factor, or TNF inhibitors.
There are 5 major TNF inhibitors available in Australia. Adalimumab, widely known as Humira, etanercept, which is Enbrel, infliximab, known as Remicade, golimumab or Simponi, and certolizumab pegol, known as Timzia.
And how exactly do they work?
Here, mechanism is incredibly targeted. They are large protein molecules engineered to bind to circulating and membrane-bound TNF-alpha, completely neutralizing it before it can bind to the cellular receptors that trigger the inflammatory cascade.
There are crucial structural differences between these molecules, though, that dictate how they're used clinically. Let's look at the nomenclature. Adalimumab, the mumab suffix, tells us it's a fully human monoclonal antibody. It's typically administered via subcutaneous injection, often 40 milligrams every fortnight.
Correct. Because it's a fully human sequence, the risk of the patient's immune system recognizing the drug as a foreign invader is lower, though not zero. Now, contrast that with infliximab, Remicade. The leximab suffix indicates it's a chimeric monoclonal antibody.
Chimeric, meaning it's an engineering hybrid.
Yes, the constant region of the antibody is human, but the variable region, the part that actually binds to the TNF, is derived from mouse protein sequences.
And the human immune system is very good at spotting mouse proteins.
Exactly. The body will mount an immune response and produce anti-drug antibodies against the infliximab. These neutralizing antibodies destroy the drug's efficacy and dramatically increase the risk of severe, life-threatening infusion reactions.
So how do we prevent the immune system from attacking the drug?
This is a vital prescribing rule. Infliximab must be administered concurrently with methotrexate. The methotrexate suppresses the immune system just enough to prevent the formation of those anti-drug antibodies.
Ah, that makes sense.
Additionally, because infliximab is administered as a weight-based intravenous infusion, it must be given in a monitored clinical setting equipped to handle anaphylactic infusion reactions.
We also have etanercept in Braille. The anacept suffix tells us it's not a true monoclonal antibody.
Etanercept is a recombinant fusion protein. It takes the human TNF receptor and fuses it to the constant Fc region of a human IgG1 antibody. It acts as a decoy receptor, floating in the circulation and mopping up the excess TNF-alpha. It's typically dosed via subcutaneous injection once weekly.
If a patient fails a TNF inhibitor, the PBS allows us to switch classes to the non-TNF biologics. Let's discuss abatacept, known as Orencia. I love the mechanism of this drug. Earlier, we talked about the two keys needed to activate the T cell, specifically that CD80, CD86 handshake with the CD28 receptor. I always explain abatacept as the bouncer at the nightclub of the immune system.
It is a perfect way to visualize it. The lymph node is the nightclub. The antigen-presenting cell is an aggressive VIP trying to get inside to start a riot. The CD28 receptor is the door.
And abatacept is the bouncer?
Abatacept is a fusion protein specifically designed to bind to the CD80 and CD86 molecules on the antigen-presenting cell with a much higher affinity than the natural CD28 receptor. It steps in front of the VIP, puts a hand on their chest, and blocks the interaction.
So the T cell just never gets the signal.
Because that second co-stimulatory signal is blocked, the T cell never activates. The inflammation is stopped before the fire even ignites. It's often initiated with a weight-based IV loading dose, followed by weekly subcutaneous injections.
Next is rituximab, available as Mabthera. This drug shifts the target entirely away from T cells and cytokines, focusing squarely on the B cells.
Rituximab is a chimeric monoclonal antibody directed against the CD20 antigen, which is found on the surface of pre-B and mature B lymphocytes. When rituximab binds to CD20, it flags the B cell for destruction, leading to a profound, rapid depletion of B cells from the circulation and the synovial tissue.
And why do we want to wipe out the B cells?
Without B cells, you severely reduce the production of rheumatoid factor and ACPA autoantibodies, and you remove a key cell that presents antigens to T cells. Interestingly, clinical data shows that patients who test positive for rheumatoid factor or ACPA have a significantly better therapeutic response to rituximab than seronegative patients.
But Mabthera comes with some of the heaviest box warnings in our arsenal.
It demands immense respect because it causes profound, long-lasting B-cell depletion. The risk of fatal infusion reactions is high, particularly with the first dose. It carries severe warnings for hepatitis B reactivation. It can trigger fulminant hepatic failure in patients with latent Hep B. And crucially, it carries a warning for progressive multifocal leukoencephalopathy, or PML.
Explain PML because it is honestly terrifying.
PML is a rare, highly lethal demyelinating infection of the central nervous system caused by the reactivation of the JC virus. Most adults carry the JC virus harmlessly in their kidneys. But when the immune system is severely compromised, particularly the B-cell compartment, the virus can cross the blood-brain barrier and destroy the myelin sheath of the neurons.
Which leads to what?
It leads to rapid cognitive and motor decline and usually death. Pharmacists must monitor for any new neurological symptoms in these patients. It's administered as 2 large 5E infusions separated by 2 weeks, often not repeated for 6 to 12 months.
The final major non-TNF biologic class are the interleukin-6 inhibitors, tocilizumab, known as Actemra.
IL-6 is the primary cytokine responsible for driving the hepatic acute phase response. It's what tells the liver to churn out CRP. Tocilizumab binds directly to the IL-6 receptors, both soluble and membrane-bound, rapidly shutting down this systemic inflammatory pathway. It can be administered IV every 4 weeks or subcutaneously weekly.
Okay, we have covered the conventional synthetics and the massive biologic proteins. Now we reach the newest frontier in RA treatment, the targeted synthetic DMARDs, or TSDMARDs, specifically the Janus kinase, or JK inhibitors. In Australia, we frequently dispense tofacitinib, which is Xeljanz, and upadacitinib, known as Rinvoq. What fundamentally separates a JAK inhibitor from a biologic?
The defining difference is molecular size and delivery. Biologics are massive, fragile, complex proteins grown in living cell lines. They must be injected or infused because the acidic environment of the gut would instantly digest them. JK inhibitors are synthetic small molecules manufactured chemically.
Which means they can be a pill.
Because they're tiny, they can be formulated as oral tablets.
It sounds like the holy grail, a highly effective targeted therapy without the burden of cold chain storage or needles. But the mechanism of action is distinctly different. They don't float around in the blood soaking up cytokines.
Exactly. Biologics work extracellularly. JAK inhibitors work intracellularly. Let's look at the JAK-STAT pathway. When an inflammatory cytokine, like IL-6, binds to its receptor on the outside of a cell, the receptor relies on enzymes attached to its intracellular tail to transmit the signal to the nucleus. These enzymes are the Janus kinases, or JAKs.
They're like the telegraph operators at the cell.
Precisely. When the cytokine binds, the JAK enzymes phosphorylate each other. They activate. Once activated, they recruit another group of proteins called STATs. The STATs dimerize, travel deep into the nucleus, and instruct the cell's DNA to manufacture more inflammatory mediators.
So where does the drug come in?
A JAK inhibitor, like tofacitinib or upadacitinib, crosses the cell membrane, binds directly to the ATP binding site of the JAK enzyme, and shuts it down. The telegraph line is cut. The nucleus never gets the message to cause inflammation.
While the oral administration is a massive win for patient convenience, the safety profile of JAK inhibitors has been under intense scrutiny recently.
And for good reason. Following large-scale post-marketing studies, specifically the oral surveillance study, major regulatory bodies globally, including the TGA in Australia, updated the warnings for this entire class.
What are the main concerns?
JAK inhibitors carry severe warnings for an increased risk of serious cardiovascular events, heart attacks, and strokes compared to TNF inhibitors. They also carry a heightened risk for venous thromboembolism, meaning deep vein thrombosis and pulmonary embolisms, as well as an increased risk of certain malignancies and severe infections like herpes zoster or shingles.
So before a pharmacist dispenses Rinvoq or Xeljanz, they need to perform a mental risk assessment of the patient standing in front of them.
Absolutely. If Sarah's over 65, has a history of smoking, or has significant existing cardiovascular or thrombotic risk factors, a JAK inhibitor might not be the safest choice. The prescriber must weigh those heavy risks against the convenience and efficacy of the oral molecule.
We've built this incredible pharmacological arsenal. But let's bring it back to the realities of the Australian pharmacy system. Having a drug exist doesn't mean Sarah can just walk in and buy it. These biologics and JK inhibitors are modern miracles, but they are astronomically expensive. How does the Pharmaceutical Benefit Scheme, the PBS, manage this?
This is the administrative hurdle every Australian pharmacist and rheumatologist navigates daily. The PBS heavily subsidizes these advanced therapies, but the access is strictly regulated by authority prescriptions.
Huh?
The ETG and PBS guidelines enforce a step therapy paradigm. A patient cannot jump straight from diagnosis to a biologic.
They have to prove that the cheaper conventional drugs have failed.
Yes. Typically, the prescriber must demonstrate that the patient has undergone an adequate trial, usually at least 6 months, of intensive conventional synthetic DMARD therapy. This includes methotrexate at a maximum tolerated dose, often in combination with another agent like leflunomide or sulfasalazine.
And they need proof of disease activity, too.
Furthermore, the rheumatologist must document a continuously high disease activity score, like a specific days 28 or ESR-CRP level, to prove the patient has severe refractory disease. Only then will the government approve the authority code to subsidize the biologic.
If they don't meet those exact administrative criteria, they have to pay out of pocket, which for a biologic could be thousands of dollars a month. But there's a massive shift happening in the landscape that's changing the economics of RA treatment, the integration of biosimilars.
Biosimilars are revolutionizing access by significantly driving down costs. But we must be precise with our terminology. A biosimilar is not a generic drug.
Right, they are very different.
A generic drug, like generic ibuprofen, is a small chemically synthesized molecule. You can replicate it atom for atom. Biologics are massive proteins produced by living cellular factories, like engineered Chinese hamster ovary cells. Because they are produced by living organisms, there is natural variability. You can never create an exact, identical clone of the original reference product.
I use the theater understudy analogy here. If the original reference biologic, say, the original Humira, is the star actor who has played the role for 10 years, the biosimilar is a highly trained, elite understudy. They aren't the exact same biological person, but they've studied the role flawlessly. The regulatory bodies, like the TGA, ensure they deliver the exact same performance, the exact same clinical efficacy, and the exact same safety profile.
That is exactly how the TGA evaluates them. They must demonstrate no clinically meaningful differences from the reference product. However, from a pharmacy practice standpoint, the concept of interchangeability is critical. Can a pharmacist automatically substitute a brand-name biologic for a cheaper biosimilar at the dispensary level without calling the doctor?
In Australia, this is governed by the TGA as a flagging system, right?
Correct. The TGA will designate a biosimilar as a flagged if it determines that substituting the reference product with the biosimilar is safe and appropriate. If it's a flagged on the PBS schedule, the pharmacist can generally substitute it, provided the prescriber hasn't explicitly ticked the brand substitution not permitted box. However, pharmacists must handle this transition with immense care.
Because of the nocebo effect?
Partially the nocebo effect, where a patient believes the new, cheaper version won't work as well, so their symptoms actually worsen. But also because the device might be different. The auto-injector pen for the biosimilar might operate differently than the pen they're used to. The pharmacist must provide comprehensive education on how to use the new device to ensure adherence.
Let's shift into the critical monitoring and safety parameters. This is where the pharmacist actively prevents hospitalizations. When a patient is on these heavy-hitting DMARDs, what routine blood monitoring must we ensure is happening?
For conventional synthetics like methotrexate and leflunomide, routine monitoring of full blood counts, or FBCs, and liver function tests, LFTs, is mandatory. You are actively surveilling for silent bone marrow suppression and hepatotoxicity. Initially, this is done every 2 to 4 weeks, and then extended to every few months once stable.
But for the newer agents, the IL-6 inhibitors like Actemra and the JAK inhibitors like Xeljanz and Rinvoq, we add a lipid panel to that list.
Yes, both IL-6 inhibitors and JAK inhibitors have a well-documented propensity to elevate total cholesterol, LDL, and triglycerides. Given that we established RA, patients already have a massively elevated cardiovascular risk profile. Compounding that with drug-induced hyperlipidemia is a clinical tightrope.
So what's the action plan there?
Pharmacists must ensure lipid panels are checked at baseline and monitored regularly. If the lipids spike, the patient may require the initiation of a statin to mitigate that risk while maintaining the DMARD therapy.
Now, let's address the most acute, immediate risk of all these therapies: infection. We are intentionally suppressing the immune system's ability to fight off invaders. There is one specific infectious scenario that every pharmacist must understand at a mechanical level: the reactivation of tuberculosis.
This is a classic board exam question and a critical clinical reality. The risk of TB reactivation is the shadow that follows all TNF inhibitors.
Let's explain why that is.
To understand why, you have to look at how a healthy body handles a tuberculosis infection. Often, the immune system cannot completely eradicate the mycobacteria from the lungs, so instead it builds a biological prison wall around the bacteria to trap it and keep it dormant. This wall is called a granuloma.
And what holds the bricks of that wall together?
Tumor necrosis factor alpha, TNF, is the vital mortar that maintains the structural integrity of the granuloma.
So if we prescribe Humira or Enbrel to neutralize TNF-alpha,
We dissolve the mortar. The granuloma liquefies and collapses. The latent silent tuberculosis is suddenly released and reactivates, spreading rapidly and aggressively throughout the lungs and the body. It is a catastrophic event.
Therefore, the absolute rule before dispensing a biologic is strict screening.
Every single patient must be screened for latent tuberculosis, usually via an interferon gamma release assay, like a quantiferon gold blood test and a chest x-ray, before the very first dose of any biologic or targeted synthetic DMARD. We also strictly screen for hepatitis B and hepatitis C, as these can also reactivate.
What if they test positive for latent TB?
If latent TB is discovered, the patient must complete at least 1 full month of targeted antituberculosis therapy to clear the bacteria before the rheumatologist will initiate the biologic.
What happens if a patient currently stabilized on a biologic comes into the pharmacy with a prescription for antibiotics for a severe acute infection? Let's say a serious lower respiratory tract infection or a severe urinary tract infection.
This requires a temporary pause in therapy. During an acute, significant infection, particularly one requiring antibiotics or hospitalization, biologic therapy and targeted synthetic DMARDs should generally be withheld.
You just can't fight a fire from both sides.
You cannot ask the body to fight a raging bacterial infection with one hand tied behind its back by an immunosuppressant. Once the infection fully resolves and the antibiotics are finished, the DMARD can be restarted.
This highlights the paramount importance of preventative care, vaccinations. If we are deliberately suppressing the immune system, how do we handle vaccines?
The overarching strategy is to maximize the patient's protection before the immunosuppression begins. The ETG strongly recommends that all non-live vaccines, such as the annual influenza vaccine, pneumococcal vaccines, and the recombinant zoster vaccine, Shingrix, be administered prior to initiating DMARD therapy to ensure an optimal immune response.
But the critical safety intervention for pharmacists revolves around live vaccines.
Live attenuated vaccines contain a weakened form of the actual virus. In a healthy person, it causes a mild immune response. In a patient taking a biologic DMARD or a JAK inhibitor, their suppressed immune system may be completely unable to control even the weakened virus. Administering a live vaccine can cause a full-blown, potentially fatal infection from the vaccine strain itself.
So if Sarah walks into the pharmacy, she's on Humira and she's planning a trip to South America and asks for the live yellow fever vaccine, or perhaps a booster of the live measles, mumps, rubella vaccine.
You must intercept and refuse that vaccination. Live vaccines are explicitly contraindicated during treatment with DMARDs and DMARDs. It requires a significant washout period, often months after stopping the biologic, before a live vaccine can be safely administered. This is a non-negotiable safety check.
Let's explore one of the most complex special populations we see in the pharmacy, young women of childbearing potential. RA frequently strikes women in their 20s and 30s. Navigating family planning while managing a highly destructive disease requires immense clinical finesse. Let's start with the absolute contraindications.
Methotrexate is the primary danger here. It is an absolute contraindication in pregnancy. It's classified as an abortifacient and a profound teratogen. It causes spontaneous abortion and severe structural anomalies, including limb defects and central nervous system malformations, known as fetal methotrexate syndrome.
If a patient on methoblastin wants to conceive, what's the timeline?
She must discontinue methotrexate at least 3 months prior to attempting conception to ensure the drug is completely cleared and the intracellular folate stores are replenished.
And what about men?
This isn't exclusively a female issue. Male patients taking methotrexate should also receive conservative counseling regarding fertility. While the data on male-mediated teratogenicity is mixed, the conservative approach often recommends a washout period for men before attempting to father a child as well.
Leflunomide is also heavily restricted.
Highly teratogenic. As we discussed earlier, if a patient on Arava wishes to conceive, simply stopping the drug is inadequate due to the 2-year clearance time. They must undergo the rigorous cholestyramine washout procedure until blood tests confirm the drug levels are undetectable.
So we strip away methotrexate and leflunomide. But Sarah still has active RA, and if her disease flares violently during pregnancy, the systemic inflammation itself is a risk to the fetus. What are the safer options to keep the fire under control?
The ETG supports the continuation of certain conventional DMARDs during pregnancy. Hydroxychloroquine, Plaquenil, is generally considered safe and is often continued. Sulfasalazine can also be used, provided it's supplemented with high-dose folic acid, usually 5 milligrams daily, because sulfasalazine also interferes slightly with folate absorption.
But what if her disease is so severe that she requires a biologic during pregnancy?
Most TNF inhibitors cross the placenta, particularly in the 3rd trimester. While they aren't generally linked to severe congenital malformations, they can cause profound immunosuppression in the newborn. If a mother receives a standard biologic late in pregnancy, the newborn must absolutely not receive any live vaccines, like the rotavirus vaccine, for the first 6 months of life, as the biologic remains active in the infant's bloodstream.
But there's one biologic that completely circumvents this issue through brilliant bioengineering. Certolizumab pegol, or Cimzia, why is this the preferred biologic during pregnancy?
It comes down to the microscopic structure of the drug and the placenta. The placenta contains specific transport receptors, called FcRn receptors, that actively grab maternal IgG antibodies by their Fc region and pull them across into the fetal bloodstream to provide passive immunity.
Okay, so it pulls the antibody across.
Right. But certolizumab pegol is not a full antibody. It's only the Fab fragment, the active binding part, attached to a large polyethylene glycol molecule. It completely lacks the Fc region. Because it has no Fc region, the placental receptors cannot grab it. Therefore, there is virtually zero active transfer across the placenta. The mother gets the full systemic anti-inflammatory effect, but fetal exposure is incredibly low.
That is the power of targeted drug design. Now, as we bring this deep dive to a close, let's synthesize everything into a practical mental checklist for the pharmacist. When Sarah walks up with a script for her RA medications, what should be firing in the pharmacist's brain to ensure we are optimizing her therapy and preventing harm?
The clinical review at the dispensary should follow a logical sequence. First, immediately verify the methotrexate dosing. Confirm once weekly, verbally, check which day of the week they take it, and ensure their folic acid prescription is current and understood.
And second?
Second, conduct a bridge therapy review. Look back through their dispensing history. If they have been picking up regular prednisolone for more than 3 to 6 months, you must initiate a conversation. Ask if their pain is controlled.
And if it isn't?
If it isn't, their DMARD regimen needs escalation. If chronic steroid use is truly unavoidable, ensure they are prescribed adequate calcium and vitamin D supplementation, and discuss the need for a bisphosphonate to actively protect their bone density from steroid-induced osteoporosis.
Third, assess their adherence and the practicalities of administration. If they are on a subcutaneous biologic, ask about injection site reactions. Are they rotating their injection sites properly around their abdomen and thighs? If they are on sulfasalazine, are they experiencing severe nausea? Perhaps they need to titrate the dose slower or ensure they take it with a substantial meal.
Fourth, reinforce infection vigilance. The immunosuppression is real. Counsel every patient that they cannot ignore what might normally be a minor symptom. A persistent low-grade fever, unexplained weight loss, a lingering cough, or night sweats must be reported to a doctor immediately, particularly if they're on a biologic or a JAK inhibitor. They need to understand the threshold for seeking medical attention is much lower now.
And finally, evaluate their use of over-the-counter and prescribed NSAIDs. Sarah was picking up ibuprofen alongside her scripts.
We must remind patients that while NSAIDs are excellent for acute symptom relief, they're purely a Band-Aid. They do absolutely nothing to alter the disease course or prevent the osteoclasts from destroying the bone. Furthermore, they compound the cardiovascular risk and renal risks that are already elevated by the RA itself. NSAIDs should be utilized strictly at the lowest effective dose for the shortest possible duration, leaning on the DMARDs to do the heavy lifting of disease control.
This has been an incredibly thorough breakdown of a highly complex disease state. To wrap up, let's distill this entire conversation into the core clinical takeaways for our listeners.
The foundational concepts are clear. RA is a systemic, inflammatory autoimmune condition driven primarily by an activated T-cell cascade. It causes rapid, symmetric, irreversible joint destruction, and is characterized by prolonged morning stiffness.
We must recognize that cardiovascular disease is the primary driver of mortality in these patients. The systemic fire damages blood vessels independently of traditional risk factors. Aggressively suppressing the RA is cardiovascular protection.
The treatment paradigm is treat to target. Early and aggressive initiation of DMARDs is the only way to halt bone degradation. Bridge therapy with corticosteroids is effective, but must be limited in duration to prevent devastating long-term toxicities.
Methotrexate is the undisputed king of initial therapy. It must be dosed strictly once weekly to trap the polyglutamate drug inside the cell, and it must be supplemented with folic acid to rescue the healthy tissues.
When escalating therapy, we use combination to conventional DMARDs and then progress to biologics or targeted synthetic JK inhibitors under strict PBS authority guidelines. However, you must never combine a biologic with a JAK inhibitor or combine 2 biologics together due to the profound risk of fatal immunosuppression.
We must remain vigilant against infection. Strict screening for latent tuberculosis and hepatitis is mandatory before initiating advanced therapies, as drugs like TNF inhibitors will dissolve the granulomas, keeping those infections in check. And live vaccines are an absolute contraindication during therapy.
Finally, we must navigate family planning proactively. Methotrexate and leflunomide are profound teratogens that require long washout periods, while highly engineered biologics like certolizumab pegol offer safer alternatives due to their inability to cross the placenta. If pharmacists master these pillars, they are providing world-class, life-saving clinical care.
Before we log off, I want to leave you with one final provocative thought to mull over during your next shift. We discussed earlier how the immune system begins producing those anti-citrullinated protein antibodies, the ACPAs, in response to environmental triggers like smoking. Research shows that high titers of ACPA can be detected in a patient's blood up to 10 years before they ever feel a single ache, notice a swollen joint, or show any damage on an X-ray.
10 whole years.
Right. The systemic fire is smoldering silently for a decade. Given what we know about the irreversible nature of joint destruction once the pannus forms, are we approaching an era in rheumatology where we might treat RA before the disease physically manifests? Imagine a future where we routinely screen high-risk populations for ACPA, and if positive, we initiate heavy immunosuppressive therapy, perhaps a biologic, in a completely healthy-feeling, asymptomatic patient. Our goal would be to prevent the joints from ever degrading in the first place. But how would that shift the ethical and clinical landscape of pharmacy? Exposing a healthy person to the risks of severe infection and malignancy to prevent a disease that hasn't fully arrived yet. It's a profound clinical dilemma, and it is something to think about. If you want a quick revision of rheumatoid arthritis, check out the quick dose version of this episode.